So our today's topic is hip dislocation. Why I chose it? Because it is very commonly asked in the examination. And secondly, it is an orthopedic emergency. All the students and the doctors must know the basic management of orthopedic emergencies because it will be they who will be doing it in the dead of the night or any time that patient is coming. And that's why there are certain subjects which is must know or some subjects they are may know. This is the subject and topic which is must know. So we know it, the hip dislocation is not so common, but because it is an orthopedic emergency, we have to take it as a very important subject. The injuries to the small joints and their dislocation thereupon is common, not the hip. Say, for example, fingers, the interphalangeal, metacarpophalangeal joints, or wrist and elbow, but not the hip. And the reason is simple because a very large force is required to dislocate the hip. And it usually comes from the motor vehicle accident that we'll be seeing in subsequent slides. And usually it is associated with a very serious morbidity unless it is taken care of very carefully in the first hour itself. Out of the dislocations, remember 70% are all due to the motor vehicle accidents. Sports contribute little of it. Say, for example, the football injuries, 3% can happen there. But there are certain rugby or skiing, snowboarding, they are the sports where hip dislocations can happen. So usual mode of the problem and the dislocation is road traffic accidents and certain sports. And even in the road traffic accidents, it's usually the high speed vehicles that can cause the hip dislocation. Now we'll see a little bit of the anatomy because we want to see how the hip is stabilized and what are the factors which are contributing to the stability of the hip. So first is the articulation of the acetabulum and the head. It is a very nice stability given by the bony contours. There is a cup and in the cup is seated the head, a ball. Then there are ligaments. Remember, there are usually the 5 ligaments, the iliofemoral ligament, the pubofemoral ligament, ischiofemoral ligament, and transverse vertebral ligament, which is not so important. There is a ligament, but it does not contribute much to the stability. It is the weaker one. And the another weaker one is the ligamentum teres, also called femoral head ligament. And through it, an artery is also supplying the head of the femur. So these 5 ligaments, remember, some of them are the strongest ligament in the whole body. The blood supply is a problem for the cases in dislocation as well as in the fractured neck of the femur. And subsequently, if there is a loss of blood supply to the head, it goes for the avascular necrosis and then it is deformed and ultimate result will be an osteoarthritis. The blood supply is given by the medial femoral circumflex artery. This is the main blood supply for the weight-bearing portion of the femoral head. There is another artery which is artery to the ligamentum teres, and its supply is only 10 to 15% of whole head. Femoral circumflex artery, the main blood supply to the weight-bearing portion, the artery to the ligamentum teres, which supplies only 10 to 15% of the area, and there is an obturator artery which supplies a part of the head, which is perifoveal area. The classification of the dislocations, there are three types usually discussed. So classification of the posterior hip dislocation, one is anatomic classification. It is based on the anatomical location where the head of the femur is lying after the dislocation has happened. The second one is Thompson-Epstein classification. It is based on radiographic findings and based mostly on the fractures. And the third one, the Steward and Milford classification. It is based on the functional hip stability. Again, mostly the radiological findings tell us. The anatomic classification is very simple. Either it could be anteriorly placed head or it could go posteriorly. Remember, the posterior hip dislocation is by far the commonest one. 90% of the cases are posterior dislocation of the hip. And in the examination, they will ask most of the time about the posterior dislocation. Now, the classification, I will discuss just only one to show how radiologically we describe it. This Thompson-Epstein classification, which is based on the radiological findings, they will talk about the fractures happening there. So type 1 is there is no fracture, or there is a fracture which is a very minor one. Type 2 is there is a fracture which is large and it is over the posterior acetabular rim. Remember, the head of the femur is going posteriorly and it is passing through the posterior acetabular rim, thereby fracturing it. The third one is when the posterior acetabular rim is fractured and there is a comminution also, so it is difficult to repair it. And the fourth one is when the floor of the acetabulum itself has been fractured. And the last one is when femoral head is fractured. So just to show you, we won't be spending our time on a Steward and Milford classification. It is almost the same way we do it. Then let us start our clinical parts, how to take the history. The typical history of the hip dislocation will be, if it is motor vehicle accident, we say it is dashboard injury. There is sudden deceleration or the car has stopped from high speed and the passenger or the driver, they have hit the dashboard with the knee bent. The athletic injuries, usually an athlete is running and lands on the fit or the flexed knee, is striking the ground while the hip is flexed, adducted and internally rotated. Remember, when the hip is flexed and adducted, the posterior part does not give much of the stability for the head. It is a deficient one and the head can go posteriorly. There, transverse ligament is there and there is a deficiency there. The clinical presentation will be usually the severe pain. Patient will not be able to walk and cannot straighten the limb because there is a deformity. We will discuss about the deformity later. And don't forget, neurovascular damage can happen in this particular case. When we try to examine, we start with orthopedic examination with the inspection. So attitude will be seen first, and attitude is a very, very pathognomonic. The hip will be internally rotated, flexed, and adducted. In posterior hip dislocation, I have not written here flexed, you can add internally rotated, flexed, and adducted. In anterior hip dislocation, it may present in two different ways. There are two types. One is superior and one is inferior type. When it is superior type, it presents with the hip extended and externally rotated. Compare with the posterior hip dislocation where there is opposite of the deformity. But in inferior type of the anterior dislocation, hip is flexed, but abduction and external rotation remains. So when we examine on inspection, apart from the attitude, we have to look for the swelling. Swelling is very widespread because it has ruptured the capsule, it has ruptured the ligaments and many of the soft tissues. So there will be swelling in the femoral triangle, and apart from the swelling in the femoral triangle, there will be swelling in the gluteal region as well. The deformity we have already discussed in attitude, it is same. Deformity is hip is in fixed flexion, adduction, and internal rotation. There is shortening. If we put both limbs in similar position, medial malleolus will be up on that particular side. And for the skin around the lesion or the hip, usually there will be bruises and ecchymosis because it is very high velocity injuries. When we try to palpate, remember temperature is to be taken first and it is usually raised. The tenderness can be felt anteriorly and especially posteriorly because deformity, which is adduction, flexion, and internal rotation, has to be confirmed. Swelling is to be confirmed by putting the fingers there, and shortening is to be confirmed by putting your fingers over the medial malleoli. Now there are two special parts which comes in the palpation. This is vascular sign of Narath. Vascular sign of Narath is there is absence of the femoral pulsations when you try to feel it, or femoral pulsations are weak. And the reason is head of femur is not there. We feel the femoral pulsation by pushing it over a hard object, which is head of the femur. And then we feel it in the full form. And we must try to feel for a globular bony mass in the gluteal region. And to confirm that it is head and not some chip of the bone, you have to move the shaft of the femur. And when this globular mass moves with the shaft of the femur movement, it is confirmed that it is head of femur only. Now the movement measurement, which is a definite sequence of the examination, remember movement is very painful and not to be tried even. Measurement, if you try, it will be definitely shortened, and especially in the femoral component. And if at all you can draw a branch triangle, that will be also, the base will be shortened. The neurovascular examination is to be done for the sciatic nerve injury. Usually there is neuropraxia. And there is one special test that can be done. And this special test is called telescopy test. Not usually done because it is very painful, but in old cases, you can do it. And it is simple. The hip is flexed 90 degrees and you have to push the femur in its longitudinal axis and feel for the movement of the head from the other hand, which is around the head of the femur in gluteal region. And you will find, or you can feel the greater trochanter, which is moving up. And this is how it is done. If I can show you. And now it is being pressed in its longitudinal axis of the femur and it will move. Okay, so what could be the differential diagnosis? The contusion simple, but must be remembered the femoral neck fracture or the trochanteric fracture is to be ruled out. There could be a case of snapping hip syndrome, and there could be subluxation or the dislocation. What are the investigation that is usually sought? We know the X-ray is a very cheap, easily available method of investigation, and this is the case where you take the good X-ray and you will be able to confirm your diagnosis. And it is usually done in anteroposterior and lateral view and oblique views. We'll come to that one by one. In oblique views, it can be internal oblique view or external oblique view. So on the whole, the X-ray is done AP lateral and oblique views. In oblique views, internal oblique and external oblique views. Now, there could be a cross-stable lateral view that we were talking about, the lateral view. And there could be an oblique view, which is called Judet oblique views. First oblique view is taken with the patient placed on the injured side and the angle anteriorly about 15 degree. And the second view is taken with the patient's supine and angle upward about 60 degree. So this is the X-ray you take. This is the oblique view. You can see it. This is the oblique view. So almost whole neck, and clearly you can see head out of a sternum. When to do CT? CT is done in certain circumstances, not the usual mode of identifying that there is a dislocation. When you try to do the close reduction and you fail, so you want to know what is the cause behind it, and probably CT will tell you. Or when you reduced it, but on the X-ray you find that the joint is not reduced concentrically, meaning there is a cup and there is head and they are not concentrically reduced. One is away and one is, so there is a mismatch. Then probably CT will help you. Or else you reduced and there is a widening of the space. Still you feel there is something there which is widen the space between the sternum and the head. MRI, when to do? It is done for the tissues which are not coming on the X-rays. Say for example, for the labral tears, chondral injuries, or when you suspect there is a loose body which may prevent a concentric reduction or can widen the joint space, then you have to do the MRI. Or many times, to understand and to know the avascular necrosis of the head of the femur, you do this MRI. Many times you have to do it in 4 to 6 weeks after the reduction has been achieved. And then repeat after 3 months to rule out or confirm the AVN, avascular necrosis. Now, when you see the X-ray, you have done it. Usually, you will be given AP view of the pelvis, including both hips. And you have to diagnose and have to come to a conclusion by your findings. Or what could be your findings that will tell you that it is a case of dislocation of the hip. So the findings are for the posterior dislocation I am trying to tell you. So head will be found not in the sternum. So head is not in the sternum. Head of femur is usually lateral to the sternum and superior as well. On the X-ray, the shape will appear smaller compared to the injured site, uninjured site. So head of the femur appears smaller when you compare with the uninjured or normal site. The central line is broken. The lesser trochanter is less prominent because it has further gone posteriorly. It is usually in the medially and posteriorly placed. When there is internal rotation, it disappears. And also, the lesser trochanter is placed superiorly compared to normal side as well as the greater trochanter. And you can see the femur adducted. So we'll try to see it. You can see the central line. This is the central line. So if you draw here, this central line is broken. It has gone here. So it cannot be like this. So central line is broken now. Again, you can see the central line, nice one. And if you draw here, it is not there. This has inferior border. So central line, you can see the inferior border of the superior pubic, iliopubic ramus, and then it goes and then meets with the inferior border of the neck of the femur. Here, if you trace it from the inferior part of the iliopubic ramus, it goes, and then because the inferior border of the neck has gone up, it is discontinued. So this central line is broken. You can see very clearly, this is broken here and this is continuous here. Broken because this has shifted up. Now you can see in all the fractures, a sternum is here and the head is lateral and superior. Everywhere it will be lateral and superior. And you can see the femur adducted. You can see the femur adducted. Can see the femur adducted and lesser trochanter almost not visible. It has become invisible. And now we come to the anterior dislocation. It is usually happens when there is a direct blow on the posterior surface or aspect of the abducted and externally rotated thigh. It can occur due to fall from a height or an impact with the leg in this position during a high energy contact sport. And there are three types of the anterior hip dislocations. One is obturator. It is inferior dislocation due to simultaneous abduction and hip flexion and external rotation. Iliac is one. And pubic dislocations, they are superior dislocations, gone up. Pubis, we know it is at the level or a little superior to the sternum. We know it, there are two types. So superior dislocations are two, iliac and pubic. And inferior dislocation, they are obturator, thyroid, or perineal. So it can go anywhere. So in case of the superior dislocations, hip is extended. Compared with the posterior dislocation, it was flexed. Here it is extended. And externally rotated, there it was internally rotated. And because in iliac, you will find in the vicinity of ASIS, and it can danger the femoral artery and vein and cause thrombosis of the vein as well. Inferior dislocations, again, the externally rotated and abducted is a normal form. In inferior, there could be flexion of the hip compared to the superior where it is extended. So femoral head appears larger compared to the other dislocation, posterior one that we've seen. Femoral head is medial or inferior to the sternum, and limb is abducted. That was adducted, and lesser trochanter becomes more prominent because it is externally rotated. Management, Now, advanced trauma life support system is necessary in many of the cases because it is a very high velocity injuries. And all must remember hip dislocation is an orthopedic emergency, and that's the reason we give so much importance despite a rarity of the hip dislocation. So it should be reduced and taken care of as soon as possible, and definitely and certainly within 6 hours. There are several methods of reduction: Alice maneuver, Bigelow's maneuver, Stimson maneuver, Captain Morgan technique. So Alice is the most common one that is usually being done, where hip and knee both are flexed and an assistant stabilizes the pelvis and the surgeon pulls the femur in its own direction upward, and due to external and internal rotation, ultimately the head of the femur is reduced. So this is how it is done. One is stabilizing the assistant stabilizing, and then slowly they will lift it and make it like this, and then it will be reduced. So this is one. So Bigelow's maneuver very close to it with certain and little difference. Okay, and Stimson, we know it is the way to apply. Captain Morgan technique is something very, very different. So we won't be discussing a lot here. Okay, so on-field reduction is possible. They say it is possible if you do it within 5 to 10 minutes. Otherwise, after that, the muscle spasm will occur and the muscles are very, very strong there. They won't allow any reduction there. What is the post-reduction protocol? Reduction is to be checked by X-ray, immobilization done by skin traction, and position of hip. Usually, abduction is done an external rotation, because internal rotation and adduction, the head of the femur is likely to be dislocated again. Exercises is to be done as soon as possible within a week. Surgical intervention sometimes is needed if close reduction is not successful, or there is bony fragments which are not allowing proper reduction or concentric reduction, or else the joint is unstable. Complication could be sciatic nerve damage or recurrence of dislocation or inability to, or unreduced dislocation, inability to reduce. Avascular necrosis is a very important topic that you must know. This is the late complication. Myositis ossificans is a late complication, and osteoarthritis is a late complication. So rehabilitation is needed. Remember, avascular necrosis can occur in 40% of the patients. For that to know, serial radiographs are needed, and it is apparent after a few months. So close follow-up is a must, and many times there is a protocol in many of the hospitals that you take MRI after 6 weeks of the dislocation to rule out or confirm the possibility of avascular necrosis. Can we prevent avascular necrosis? Yes. Then generally the orthopedic surgeons have this opinion that if you reduce it within 6 hours, and certainly not late than 24 hours, you can prevent most of the AVN. And what are the signs and symptoms? There may not be any signs and symptoms. If at all, it is pain, which is localized in the groin area. But it can also manifest in ipsilateral buttock, or the same buttock, knee, or greater trochanter. So very non-specific pain sites are there. So there is some clinical signs that tells you about the AVN post-reduction after 6 to 8 weeks. If patient's range of motion, especially internal rotation, is limited, that tells you about the avascular necrosis. Or passive abduction is limited, or patients can do the straight leg raise but complains of the pain, this is one indication that the patient has got avascular necrosis. So remember that investigation is the MRI is the choice of the investigation. Bone scanning can be. So plain radiographs, serial radiographs are required. MRI is the best one. And there are some radiological staging of the AVN. There is classification of Steinberg and treatment. The core decompression is the basic treatment for the avascular necrosis. It can be accompanied with bone grafting, which is usually the cancellous autograft, or it can be a vascularized fibular graft. Thank you very much. We have come to an end.